Hello everyone, and thank you for joining us to celebrate the 20th anniversary of Bytes Global Institute. Over the past 2 decades, Bytes Institute has been a pioneer in providing exceptional education in dental implant field. 5 years ago, I had the pleasure of joining Bytes Institute. This journey began as an exciting and new chapter. Joining Bytes Institute has been nothing short of an honor, and I'm also deeply inspired by the dedication and passion of my colleagues within Bytes Institute. It was a transformative journey that not only enriched my professional life, but also improved me as a person. So, my name is Dr. Ahmed Keshkool, and today I'm going to talk about my lecture topic, which is called Optimizing Flap Techniques to Mitigate Oxidative Stress in Dental Implant Surgery. The foundation of my presentation stems from the knowledge acquired during course attending with Dr. Joseph Chacon. So we all know that blood supply to the underlying bone is coming from the soft tissue. So the soft tissue plays a key role in providing the blood supply to the underlying tissue. So how does the bone of soft tissue become ischemic? From the study of Mamato, we know that tissue either subject to excessive pressure or to excessive tension, and accordingly it will lose its vascularity. So stress is called oxidative, which means accumulation of oxidant into the tissue. From the study of Savasky, he found that either tension or pressure create both of them hypoxia, which may lead to the soft tissue stress or bone stress. Compression can be done by certain shape of healing abutment. From the study of Sergio Spinato, he found that reduction of biological width can be done by a certain type of healing abutment, which will lead to decrease of blood supply to the underlying bone and then bone ischemia. Another study, which is showing the situation of excessive pressure by Finelli, he placed a platform switch implant, subcrystal, and with different type of healing abutment, and we can notice that this type of healing abutment is making compression on the bone and it leads to bone loss, while the other type and style with no compression on the soft tissue and no compromise of the blood supply will keep the bone with no absorption. Tension is created by flap closure, which will lead to ischemia and oxidation. After teeth extraction, we will have some flap closure and sometimes we'll end up with tension. And after big augmentation, flap closure, most of the time, if we didn't do the enough release, we will end up with some tension and also in the short vestibule. These are all examples of tension created by flap closure. Flap management is fundamental. Tension induces two deleterious effects. It induces ischemia and flap oxidation, which will lead to delayed soft tissue healing and reduce blood supply to underlying bone. Also induce pressure on underlying bone, which will lead to bone oxidative stress. So what is the consequences of raising a flap? First, the flap gonna becomes mobile. And the second, the blood supply is gonna be interrupted. And that's all because of the mobility and the tension that we have. So after raising the flap, we need to understand the condition for the bone to recover its blood supply. And that happens when the periosteum reattaches. So the next question is, how long does it take to reattach? So according to the study of Scalfani in 2003, he found that periosteum reattach only 70% after 30 days, which means 4 weeks. And it may need 6 weeks for good reattachment. We conclude that reattachment of periosteum requires several weeks. Botros also found the same result. He found that attachment only 50% of periosteum after 12 days and 75% after 30 days, which is the same result as a scalfani. And now we know that all that time after surgery, there is permanent mobility and tension because the people keep talking, eating, smiling, coughing. All these activity is continuous, and there is permanent mobility and tension which we have to address. So what's the rule here? The rule is we like to have a tension-free flap closure. And how to assess the remaining tension? Simply by pulling on the lip or cheek after we finish our suture. But knowing that the tension is usually masked by local anesthesia, which means that the tension is more, even more, after the surgery, after the anesthesia will go away. Now we understand that tension and mobility, they must be assessed and managed during surgery. Otherwise, the consequences will be detrimental for the bone. It will work like crater on the wound. So one of the most important part is when we have tension in the vestibule and there will be a soft tissue stress which lead to blood supply loss. And then the end result will be a buccal bone resorption, which we often see it on the buccal zone. So if we have mismanagement of tension during surgery, this tension will persist over time and bone resorption will be an inevitable result. And that's why we always recommend that take care of soft tissue to prevent tension, and vestibuloplasty or vestibular deepening is an effective technique to stop periimplantitis, as the study of Thoma on 2018. So we have two methods to prevent soft tissue oxidative stress. We need to prevent the tension by releasing the flap, and we need to prevent the mobility by fixing the flap. So we all know that even with the clothing, comfort is biologic, while being in a tight spot is not biologic. And the same principle could be applied to a flap closure. So the first rule is to release the flap. And to stay biologic, the flap must be over-released by at least 10 millimeter or 1 centimeter. And the second rule is the immobilization of the flap. And in order to do that, we need to have an appropriate suture technique to be used. One of them is apical mattress suture. And we can see here that this is the classic suture. While on the apical, and we call it apical because it's coming deep apical on the vestibule, on the buccal vestibule, about 1 to 1.5 centimeter. And then by this, we are fixing the periosteum to the buccal bone. So what is the apical mattress technique? On the apical mattress, we usually go from the buccal deep, like about 1 to 1.5 centimeter. And then we go out from the palatal or lingual, coming back. And as you can see, we don't need to go that deep on the buccal or lingual or palatal. And then we try to go out on the same level. And then we are trying to tie our suture. You can see that we are doing translation of the gum, and we end up with a gum bead, which is kind of excessive tissue that ending after doing the apical mattress suture. So what is the apical mattress advantage? First of all is we have a vertical ascension of periosteum. We're going to end up with gum thickening. We will have very low tension on the buccal flap. And in general, the flap immobilization and tension removal, that's the main goal. And then the end result, according to this, we will have a faster revascularization of the underlying bone. So we can see that apical mattress suture has an impact on tension and mobility. We can see the advantage and the difference between apical mattress suture and classic suture. We can see the mobility is obvious here, while in the apical mattress suture, mobility is 0 and tension is 0. Now, after we understand how to do the apical mattress, for tying the suture, I follow two steps. Step number one is to make the knot flat. And to do this, step number two is to roll the needle holder toward the short end always. So this is a basic video how to make the flat knot and why we like to make it a flat. So basically we are following the short knots and bringing the short knots to the other end and then going back again toward the short. So this is a flat knot. And you can see that flat knot is staying and stay tight. And this picture of the difference between flat knot and not flat. So if I don't do a flat knot, what will happen? That not flat knot usually does not hold and it will become loose and you have to redo it again and again, or your assistant has to hold it. Step 2 of making the tie is rolling the needle holder toward the short end. In this video, we can see that we are following the short end all the time. So bringing this side, and now we are going back to pick the short end again and moving backward. As simply as that, to make a flat knot. So sometimes, despite that we did everything right, the tension remains even after apical suture, as we can see in this video. And simply by testing after the suture, by pulling on the lip or on the cheek, that there is still tension and probably mobility. In such a scenario, what if the tension remains? Simply by bringing a blade and cutting, making a mucosal or vestibular incision to relieve the pressure and the tension from the flap, simply by injecting some lidocaine with epinephrine 150 before the incision, just to minimize the bleeding that may happen after. So what is the vestibular incision advantage? It has the reduction of flap tension, which is the main goal. No post-operative pain. As I said, pain usually is coming from ischemia, so we are reducing the tension. No PRF needed to cover the incision. And most of the time there is no bleeding, because especially when we inject the lido with 150 before the procedure. So it's very there is so many advantage and no disadvantage in this procedure. So now we know that the main question is when to remove the suture and what type of suture to use after making all these procedures. Now we can go back to the study of Scalfani, and that we know that periosteum have the reattachment of 70% after 4 weeks of it. So at least periosteum need to stay 4 weeks and the suture must stay for at least 4 weeks. So now we know the duration that we need to keep our suture. So we all know that monofilament type of suture is our preferred suture in dental implant field. And we have the resorbable and the non-absorbable. So for example, we have the nylon and the PTFE. But these are inconvenient because if we leave them for 4 weeks, the threads are covered by the gum, embedded, and therefore it's very difficult and painful to remove after 4 weeks. While the resorbable type of monofilament, which is the glycolon or monoglyc, they have the ideal absorption time, which is 4 weeks, which is basically, that's the minimum week. The 3 common glycolon suture size that being used in dental implant field is the 4-0, which resolves in 5 weeks, the 5-0, which resolves in 4 weeks, this is the most we use, and the 6-0, which resolves in 3 weeks. So the advantage of glycolon and monoglyc sutures are they are elastic, they have stable nodes, no need to remove them, no pluck, sufficient time for periosteal reattachment, and significantly reduce the risk of suture disunion. At the end, if I need to define myself, I'm a dentist who loves to empower smiles and transforming life with passion. Thank you.